Thank you. I'd like to thank the organizers for inviting us to speak, and also to thank my colleagues for allowing me to present our results. I'm going to speak today about rapid initiation of antiretroviral therapy, knowing as we do that the speed with which ART is delivered can affect the improvements we see in morbidity and mortality for patients with a new diagnosis of HIV infection, as well as their reductions in transmission that can occur. We asked, our team focused on a question that involves the very left side of the continuum of care, which is, can ART be begun potentially at the day of diagnosis, such as is done for other communicable diseases, without compromising the effectiveness and the long-term effects of ART? We're aware that initiating lifelong daily oral medication is different than treatment with antibiotics for an STD, for instance. And this model illustrates the sequential milestones of engagement in outpatient care that are typically encountered by a patient who's newly diagnosed with HIV as they move from diagnosis, where their status is disclosed, to their first appointment at a clinic where they are not only registered but have their insurance status established, have their housing needs, substance use, mental health needs also assessed, as well as counseling and screening labs, to the primary care visit, which would be the first meeting with their assigned HIV physician, where typically ART readiness is assessed and ART can be begun with subsequent viral suppression. Now, these needs are paramount and are believed to be associated with better treatment outcomes, particularly for settings such as ours, which is a public health clinic setting with high needs population in San Francisco. And as such, our clinic, as many well-resourced public health clinics in the U.S., attends to patients' needs with a multidisciplinary team involving social workers, nursing, and medical providers. However, no matter how well-resourced or well-experienced and coordinated this response is, this sequential kind of care does take time. Using this model of care milestones, we looked at the time to achieving these engagement milestones in our clinic. Between 2006 and 2009, looking at patients during this CD4 guided era, it took approximately 128 days for patients to begin ART and 218 days to reach the WHO threshold of 200 copies per mil, indicating viral suppression. In 2010, San Francisco instituted universal ART citywide with new guidelines ahead of similar national guidelines, reducing the time to initiation of ART in our clinic to 37 days and time to suppression to 132 days, or approximately 4.5 months. So this was the bar in 2013 when we asked whether same-day initiation of antiretroviral treatment would be possible. The approach that was proposed looking at these data was to attempt to collapse the first several steps in this, the first several milestones that patients achieve into a single visit. The rapid approach that differs from the sequential visit approach by in several key respects. First, the visit is more intensive and takes somewhat longer and involves more people from the clinic in an initial ART initiation visit. Second, it takes place on the day, ideally, of the patient's diagnosis or on the day that they are referred by telephone to our clinic from an outlying testing site. Third, ART is begun at the rapid visit. It is started after a brief medical evaluation, but prior to laboratory results, and including genotype results being available. And lastly, the role of the assigned primary care provider who will care for this patient in follow-up changes from that at the first meeting, from that of ART initiation to that of initiating ART management and monitoring for a patient for whom ART has already been initiated. This model was implemented as a program we called the RAPID program, and a demonstration project began in our clinic in 2013 in the month of July and continued for 18 months through December 2014 when we cut the data. We assessed during this period the overall feasibility of the program, which included a health systems intervention for same-day outpatient ART for newly diagnosed HIV infections. It was deployed in the context of existing services, which I've described, and was initially targeted to new patients with acute HIV infections, which we initially defined as HIV antibody negative within the past 6 months based on their testing history. But this, following initial demonstration of feasibility of our program, was extended in 2014 to include additional indications for urgent initiation of antiretroviral therapy, including active OIs or CD4 counts less than 200. The intervention components that constituted the RAPID program were facilitation of same-day appointments using things such as taxi vouchers for patients to get them into the clinic on the same day as their diagnosis, flexible scheduling for providers, plus the availability of an on-call provider list for backup if one within the clinic could not be identified. ART regimens were pre-approved. There was a pre-approved list which was compiled by a clinician committee based on data on patterns of transmitted drug resistance in San Francisco, as well as best current evidence. These regimens were made available as 5-day starter packs while insurance benefits were being established for patients. And we recommended that patients open their starter pack and take the first dose in the clinic in the presence of the provider for support if they wish to, if they accepted the offer of same-day ART. So our evaluation objectives with the rollout of this program were, first of all, to assess feasibility as in terms of acceptability, safety, but also the potential impact of the program in terms of its effect on the time to virologic suppression, defined again as 200 copies per mil, and the indicators we looked at are shown here. This was a planned program evaluation of a real-world implementation study. This was a clinical program, and the data that we collected were abstracted principally from electronic medical records. The analyses I'm going to report included only patients with a new diagnosis of HIV infection who were initiating their first outpatient care, and this means that we excluded records from this analysis for patients who were managed initially as inpatients or patients who may have transferred their care from a jail, another facility, or another clinic. The outcomes for RAPID patients were compared with others who received the standard sequential service model at San Francisco General, both in the contemporaneous and past time periods. We used time to event analyses using Kaplan-Meier methods to account for variable length of follow-up and data censoring in our population. Overall, our population reflected that we're used to seeing at San Francisco General Hospital. This is a high needs and medically underserved population. The mean age is in the 30s, predominantly men of color. Over a quarter of patients were homeless and none had health insurance. In all, 41% of all of our of these 86 patients were defined as having acute HIV infection by our definition of having a reported antibody negative test within the past 6 months. And this was 70% of the patients, of the 39 patients in the RAPID group, which was slightly higher proportion than the 26% in the universal ART standard of care group seen at the same time. Viral loads were high, consistent with the prevalence of acute infection, and CD4 counts in the 400 to 500 range. Transmitted drug resistance was always also, substantial. Over a third of patients had transmitted drug resistance. The rates were similar between arms, and over 20% or between groups, and over 20% of patients in both the rapid participants and patients who got the standard of care had major NNRTI resistance mutations. Integrase inhibitor testing is not routinely available. However, integrase inhibitors were used and selected as the regimen in the vast majority of cases in both the rapid starting and standard of care groups. So the main result, the first main result is that, and a very important observation, I think, is that when patients in our clinic were offered same-day ART, and this had not been done routinely before, but when they were offered same-day ART, they wanted it, and it was impressive how much they wanted it, and they took it. 35 out of 39 patients who were offered same-day ART took the pill in the clinic together with the provider at that visit that day. And all of the patients, as you can see here, were on therapy within a few weeks. Excuse me. Anecdotally, I should tell you that the reactions of patients to leaving the clinic on the day that they were diagnosed, already on ART, talking about doing something about their infection, were extremely positive. They were universally positive, and frankly, quite moving to those of us who were taking care of the patients. And this engendered an extreme amount of enthusiasm among providers, and really facilitated the implementation and the adoption of this strategy by our clinic. The other indicators of acceptability are shown here. ART uptake was high, engagement in care, difficult to define with the short 18-month period of follow-up, but appeared not to be a problem in our clinic. Transfers of care were predominantly for patients moving out of town, out of state, not transfers to other systems, and there were no requests for provider switches. There was a slight excess in the group of patients who were given the rapid treatment start of changes in their medications in the months after initiating. 26% changed their medications. There was an excess exposure to drugs. However, the switches were predominantly for simplification. For instance, changing from Truvada plus dolutegravir, which was the most common regimen, to a fixed-dose combination, including abacavir, after availability of HLA testing in the clinic. The main virologic suppression effect was quite striking. Shown here is the proportion in this Kaplan-Meier plot of patients achieving less than 200 copies on the y-axis, on the time in months to this suppression on the x-axis, showing that among the 39 patients given the rapid treatment start, the median time to viral suppression was reduced to less than 2 months. It was down to 56 days by comparison with 132 days in the universal ART group, and this was highly statistically significant. Looking at the time to achieving particular clinical milestones, it appears that this reduction in time to suppression is attributable both to the immediate start. In this plot, it shows that the median time to ART start, timed from the diagnostic disclosure, was 24 hours, but also to a shorter interval shown by the green bar here, from ART start to viral suppression, which in the universal treatment era had been 95 days, but in our data was reduced to 55 days in the rapid era. Now, it's unclear and probably merits further investigation whether this is attributable to potentially differences in an increased proportion of patients taking integrase inhibitors, possibly to an increased proportion of patients with acute HIV infection receiving treatment, but also to potentially to the fact that patients were given their medicine in the clinic and actually started ART, as opposed to being prescribed medicine and having the additional barriers associated with finding a pharmacy, picking up the meds, and then actually deciding to take them. So we're not exactly sure, but we were gratified that viral suppression was shortened. In conclusion, we believe these data show it's feasible to implement same-day ART initiation for outpatients in a public health setting with newly diagnosed HIV. Same-day ART was highly acceptable to both patients and to providers. It was associated with improved rates of virologic suppression and no excess toxicity or other adverse events in this early look at this pilot program. The expansion, however, of the RAPID model has now begun in San Francisco. It was adopted by San Francisco's Getting to Zero Consortium as one of its three main strategies, alongside with PrEP and enhanced retention efforts in the city for San Francisco to get to zero. And I'd like to acknowledge, before I finish, first of all, our patients who inspire us daily, and among the staff, Hiroyo Hitano in particular, for her inspired leadership in getting this implemented in the clinic. As well as to Dion, Clarissa, Fabi, and Sandra Torres, who have done such amazing work. And thank you.
Thank you. Questions? Number 2?
Renz Loescher from Chicago. Thanks for a really imaginative protocol. But it's, you know, we often say there's no emergency to starting ART to reassure patients. And this is almost taking that 180 degrees around from that. I didn't understand the controls were those in the universal group. What about people who didn't want to deal with it immediately or who were unable to? So that's one question. Second question is, you've got a starter pack of 5 days, so they have to come back in 5 days. Was there any fall off in folks who were able or willing to do that, to follow through and pick up the second dose of meds?
Right, good questions. The first question is whether there were patients who were offered same-day appointments, for instance, but really weren't interested or didn't show up. And anecdotally, we're not aware of any patients who were referred, in part because we made efforts to facilitate those same-day referrals, but we're not aware of any who didn't show up, but we do not have a log from the DPH, for instance, of who was attempted to be referred to our program and may not have showed up. So we don't know with 100% certainty. We do know that of the patients who were referred and where the telephone contact was made, that all of those patients did eventually come in, not all on the same day, but you saw the results for when they came in. And the other question, sorry, was, oh, right. Yes, in fact, there were follow-up visits often for patients, also, and particularly if they had side effects, they were encouraged to come back. They were allowed to, but the ART starter pack was typically dispensed along with a prescription. And if the prescription wasn't able to be written that day with them because of some problem with the health insurance initiation, it could be given electronically in follow-up. So they didn't necessarily need to come back to pick up their prescription. They would have the 5 days to be able to get themselves to a pharmacy and pick up the prescribed medication.
Thank you. Number 4?
Hi, I'm Patty Kohler from Atlanta, Georgia, and I am curious, this is a great presentation. I'm really excited about these types of things being done. And I have 2 questions for you. One is, did you get backlash from patients or staff that, quote, their first appointment isn't until October? What advice would you give to a clinic or a setting that's thinking about trying to implement something like this?
The first question is, did we get backlash? We anticipated backlash, and we did not get it. patients were given the same regimens that the providers would have provided them anyway, and the task of simplifying the regimen was still there if they wished to do that. And in some cases, providers changed the initial regimen. But we didn't have any pushback, which we did expect from our providers in the clinic. In terms of what we would recommend, I guess it's kind of an open question. I would recommend, I think the approach is going to differ for each clinic. Health systems are clearly individual, but I'm not sure I can sum it all up. I'd say do it, is what I'd say. That's what I'd recommend.
Just dive in.
Yeah.
Thank you. Number 7.
Thanks very much. Thank you very much indeed for a wonderful presentation. My name is Gitam Mburu from the International HIV Alliance and additional affiliation to the Division of Health Research at Lancaster University. We'll be very interested to see exactly what you come up with in terms of the reasons why there was a difference in time to viral suppression. So we'll keep looking at what comes from your research. But my point really is about we all know the importance of these kind of findings in terms of influencing or informing guidelines at the global level. And in your setting, you obviously did have an idea of dividing patients to either go to standard or immediate access to ART. And one of the things that we have seen in many countries in Southern Africa is that clinics are always insisting on having 3 sessions of ART counseling to assess adherence and that sort of thing. So what I wanted to find out, which you haven't presented, is what kind of methods did you use or assessment did you use to look at readiness of patients to start on the day? Because that's been a major point of contention and delay in getting people to access ART. I definitely don't think that patients need 3 visits, which has been the norm in many ART programs. Thanks.
Yeah. We essentially removed the question of whether patients were ready for ART, but let them tell us whether they were ready. And the decision was made to offer it not conditioned on them being in substance use treatment if they needed substance use treatment, or having mental health services well established, or keeping a certain number of appointments or anything. ART readiness was, patients could tell us if they were ready. And it turned out that 90% of them were ready that day, and the rest were ready shortly thereafter.
Number 7.
Yeah, hi, John Schneider from Chicago. I had 2 questions. One was for the acute infection definition. It was negative antibody test within 6 months. Was that from the San Francisco Department of Public Health previous test, or where was that from? And then my second question is, because there are so many people who were acutely or recently infected, how did you do partner services during that first visit, or how was that done? Because it seems like it would be a very important time to look for partners.
Yeah, absolutely. So there are a suite of public health interventions that need to be considered around diagnosis of acute HIV infection. And our referrals in most cases did come from public testing sites that in San Francisco all do RNA testing as part of their algorithm, and identify acute infections in about 1 in 8 or 9 cases. The definition that we used was one of possible acute HIV infection, because, and we used patient self-report of their last HIV negative test. We did not have access to a testing database or anything. It was based on a report of a negative test within 6 months, the idea being that they were now antibody positive, and we didn't know if they might still be in the period of acute infection, hyperinfectivity. But with regard, so we didn't do partner services. However, we were in close, phone contact with partner services folks. They typically did not do their interviews in our clinic. They typically took place at the testing site prior to patients actually coming to us.
Thank you. We have 3 questions. If we can have all of them, but please be brief so that we can close the session. So we'll start with number 9.
Hi, Michael Chung, University of Washington. Thank you for a very interesting talk. Just in follow-up for the previous question, your rapid start of ART reminds me of how PMTCT is started in resource-limited settings, where pregnant women are actually started on ART the same day as well. But there we actually have an issue of actually not maintaining adherence to care, and loss to follow-up occurs that's quite increased. So I'm just curious, and sorry if you said this before, in terms of how the patients or subjects presented for testing, did they want to get tested for HIV, and maybe there was a selection, and I'm just so interested in why so many wanted to start and how that contrasts with findings in other settings.
So before you answer that, if we can have the last 2, and then you can answer all of them. So number 3.
Thank you very much for your presentation. Once again, I'm Ginika, Management Sciences for Health. I'm wondering if you were able to envisage challenges that we might encounter if we're thinking about scalability of your approach. That's the first question. And then the second question I'm looking at now is I'm thinking I'm quite glad to see that you've collapsed a lot of systems just to make the process short from time to diagnosis to receiving ART. Now, I just want to find out what was the exact time from the time of diagnosis in your study to the point when the first pill was swallowed. Now, because in the settings where we work, we've been able to collapse these systems to get within 1 month, getting people to take ARVs within 1 month. However, we're still facing the challenges of adhering to the drugs, loss to follow-up because of that kind of short period of time from diagnosis to receiving ART. So I'm trying to find out what were the things you did that informed this kind of rapid approach, and also patients were able to accept it and tolerate it.
Okay, final question. Thanks.
Liz Heileman from AISMAP and the Bay Area Reporter, and this is a little bit more of a San Francisco specific question. I'm wondering, I assume you had counselors who helped people get financial coverage to continue on therapy, and I'm wondering whether most of these people would have gone through Healthy San Francisco, which is the sort of the public health program which most cities in the U.S. would not have, and how many of them might have been immigrants who were undocumented immigrants who would not be eligible for other insurance like the Affordable Care Act.
Okay, lots of questions. Do you want to?
I'll try. So taking the last question first, I do not know if there were any undocumented immigrants in this population. Just because I haven't, I just don't know. However, we certainly do take care of undocumented immigrants, and most of these patients did receive Healthy San Francisco or other public assistance. Everyone was initiated on public health insurance within a few days, or had their care transferred to after establishing that they were eligible for care at a private insurance. Some patients went to Kaiser, for instance. With regard to the differences between these outcomes and what has been seen in some other specific settings, for instance, in some PMTCT programs, I think it's tempting but maybe not wise to try and assess what the differences are and what may have caused a lack of retention in other programs that I don't know much about. I will say that the overwhelming attention and nurturing of and literally wraparound sort of approach to these patients on the first day provided a powerful sort of imprinting signal. And I am not confident that these same results would be achieved if we didn't have the same sort of dramatic embrace of a multidisciplinary team, including social workers and counselors and so forth on that first day. I understood the question with regard to specifically how long it took to get the first pill in their mouths. It was on average about a day from their diagnosis. I will say that it took that's timed from their diagnosis from the referral, which is from their results disclosure typically, and that there were in some cases weeks from their actual diagnostic test to that result appointment being made and then the phone call. So this was not always, it was typically actually not on the day that the test was taken, but on the day that the referral was made, and there's a lot of room for improvement there. Thanks.
So thank you very much, and thanks everyone for staying